Our program today is Mercy Hospital Jefferson, a community update. It's being presented by Dr. Karthik Iyer, and Dr. Iyer is the Chief Medical Officer at Mercy Hospital Jefferson in Festus, Missouri. He's been in that role since January of 2020. Dr. Iyer is board certified in critical care medicine, infectious diseases, and geriatrics, having completed fellowships at St. Louis University and Albert Einstein College of Medicine. He has held multiple leadership roles at Mercy Jefferson, including Medical Director of Critical Care Medicine and Hospitalist Services, and has been a dedicated member of the hospital's Board of Directors since 2019. A passionate advocate for medical education and quality improvement, Dr. Iyer has contributed to numerous institutional initiatives and serves on the Mercy Virtual Quality Committee Board. He earned his Master's of Health Administration from St. Louis University in 2023, further strengthening his commitment to advancing healthcare delivery. In recognition of his leadership and service, Dr. Iyer was honored with the Catholic Health Association's Tomorrow's Leaders Award in 2020, celebrating his dedication to the mission of Catholic healthcare. And that's, I have a great team who prepares remarks for me, but sometimes I add a little more. I will just say, serving on the Mercy board, I have been fortunate enough to see the great work that Mercy Jefferson is doing. And because of that, I live in Arnold, I'm closer to Mercy South, but I've switched all my doctors and all my healthcare to Mercy Jefferson. And a lot of that is attributed to your leadership. So thank you for everything you do. And now please join me in welcoming Dr. Iyer.
First and foremost, thank you for all the kind words, Tina. Thank you. It's truly an honor to be here. I think this is my first time with this audience. I hope I can give you a pretty comprehensive bird's eye view of what's been going on at Mercy Hospital Jefferson. And I mean, Dina will probably agree with this. Whenever we do something, be it the college or be it at the hospital, we always think of what will this do for the community. I work in a faith-based organization, which is Mercy, and that is exactly our approach. So there are many things we have done over the years, which we always do with the community in mind, and just wanted to share with you some of the updates that you probably might know, and some of them you might not. But there are some definitely which I feel you guys will be pretty thrilled about. So without further delay, I will just share kind of what I plan to go over with. So I plan to talk about the Da Vinci robot. I do want to talk about the new ion bronchoscopy robot. There's a new cardiac cath lab that I would like to talk about. Then, of course, there has been some recent recruitment success in the area that I would like to share. Then, a lot of you may have heard about the Farmington practice acquisition, so maybe I can share a little more details on that. Then, Lake Erie College of Osteopathic Medicine. Our partnership with them has been in the news, but I wanted you to hear firsthand from me what else are we planning. And obviously what follows subsequently is the residency, and I'll talk a little bit about it. Then some new services that have come to Jefferson that didn't exist in the past couple of years. Then some updates on research. We are not very well known for research, but I do have some updates there. And then some new partnerships that Mercy has forged. And then what does the future state look like, all right? So let's first talk about something I'm pretty excited about. So the Da Vinci robot. We are all used to our surgeons performing surgeries with the patient on the bed and a plethora of team members surrounding the bed, someone holding a limb, someone holding the forceps, blah, blah, blah. Times have changed. Times have changed to where surgeries are being done with robotic instruments. And with the robotic instruments, there is enhanced precision. Recovery times are quicker. There are very fewer complications. And it is very, I would like to say it's becoming the standard of care. So when we were on a quest to hire a urologist, we actually couldn't hire a urologist because everyone coming out of a urology residency is trained on the robot. So nobody wants to come work in a hospital which does not have a robot anymore. So I mean, these toys are fancy and pretty expensive, but I mean, if that is something our new generation of physicians are trained on, I think we need to have them. So Mercy made a big investment in this. The foundation helped, and we actually have this at Mercy Jefferson now. And this is primarily used by our general surgeons. It is also used by urologists. It can also be used by our gynecologists, though right now we've kind of limited the use just to the general surgeons and the urologists. And as everybody gets familiarized with this machine, then obviously we can let them do more surgeries. So just to give you an idea, I know the machine looks pretty intimidating, but this is the robot piece that we are talking about. And is there a laser that works?
I don't think so. I don't use a clicker, so I don't
Oh, okay, all right, that's fine. I can point out. And so this will actually be right next to the bed the patient is lying on. And the surgeon is nowhere close to the bed. He's actually quite a few feet away in this receptacle. And it's almost like, it's like a video game. I hate to use that analogy, but they actually insert themselves into this device, and they get a picture which, I mean, your naked eye cannot really give you. Very enhanced. They can even feel what they are touching. I mean, the tactile feedback that they get, whether it's an artery or a vein or just a nerve, it's just impressive. I mean, I just had the privilege of trying out a demo version when I was at one of the conferences. And you probably heard I've been board certified in 4 specialties. I probably would have done a 5th one, but my wife threatened me with divorce. So I almost thought about a surgery residency, but I held myself back. So kind of this is really going to be the standard of care in the next few years. And I'm just glad our foundation, our leadership team, they all supported, and we actually have this device. And now we have urologists, general surgeons, all inquire about, hey, you have the robot, do you need a doctor who can work with it? So clearly, we are staying ahead of the times there.
Is it by AI?
Say that again?
Is it AI?
There are some components of it. I mean, now everybody claims, I mean, AI is the thing everyone's talking about. So maybe part of that programming may have some AI components, but it's still a lot of skill from the physician, because I mean, you still have to, because anatomy in everyone isn't the same. So unless you have a comprehensive understanding of the anatomy, I mean, you can't do a good surgery. So these robots, these devices, some AI assistants would help, but it eventually comes down to the surgeon's skill set. Yeah. Then let's talk about the next robot we have. So this is the Ion robot. It's basically an advanced bronchoscopy machine. All right. So just to kind of talk about what bronchoscopy is, it's basically a scope, obviously a tube with a camera that actually goes down your airways and gets a good look at your lungs. All right. Sometimes along the airway you may have some anomalies. I mean, you can diagnose cancer, and this would be primarily used by our pulmonologists. Okay. So in the medical circles, it is unfortunately very popularly known that Jefferson County is the smoking capital. All right. So because of that much smoking, we unfortunately have a lot of COPD. We have a lot of respiratory disorders, and you know, if we have a lot of smoking, we should be expecting a lot of cancer as well. So I mean, so cancer is is different in different individuals. Unfortunately, in some it may be diagnosed at a very late stage, and the later the stage, the fewer the options available, as you would know. So in many individuals, their primary care doctors or their pulmonologists, the previous standard of care was continue to do CAT scans. And when something shows up on the CAT scan, then you would go to an interventional radiologist who, with the aid of a CT machine, will kind of try to get a biopsy from a lesion that they see in your lung, a spot. And those were always considered a little risky procedures. But again, they had to be done if you really needed a definitive diagnosis. So, and there were some lesions they would not attempt it too, because if they were small enough and not really very peripheral, it's very hard to get into those lesions without kind of disturbing something else in the way, and you don't want that. So, Kamet, the robot technology, these actually let you go to areas of the airways which wouldn't be possible before. And they can actually go and visualize lesions which you can't really visualize on a CAT scan very well, because this is direct observation. And you can also, with the aid of some other fancy tools that the pulmonologists have at their disposal, they can actually get biopsy specimens. And we've structured our program such that a pathologist is always available when they do these procedures. So they can actually take a look under the microscope or whatever tools they need to use to almost immediately say whether this is cancerous or not. In some instances, it may still have to be sent for a second opinion, which happens quite often. But if they feel very strongly confident that this is cancer, just think of it. You go in for the test, you get the test done, you know there's a strong suspicion for cancer, you get a quick appointment with your oncologist, and from Dr. Oak, who is our lead pulmonologist, and Dr. Datar, who actually do these procedures, I've heard that there are some really beautiful stories where what would ideally have taken several months, they've actually been able to start treatment on those individuals within a few weeks. As early as like 2 to 3 weeks, which is incredible, which otherwise you would just be waiting on a specimen, even to get in, do the procedure, it takes time. And also important to understand, when you do these procedures in the former format, which was interventional radiologists try to get some specimen, you may not know if you got enough specimen. So this may end up with a pathologist who may say, hey, what you've given me is not enough. So sometimes you may end up going under again, which is definitely not anyone would want to do. So with these, they would keep taking those specimens until they are definitely assured they have the right specimen, they have enough. So this should be a one-stop procedure. And I think at some point we'll actually be doing a review of all the cases. This has been with Jefferson for less than a year. But again, we made a very strong push for this just because of the amount of cancer incidents we see in our county compared to our other counties. So I think this really should help our community moving forward as well. Okay.
Is this general anesthesia?
This one, yes, the anesthesiologists are always in there. This is not something just the physician does. Yeah. Mm-hmm. Then let's move on. Oh, and by the way, going back to this, so we have 3 pulmonologists, out of which 2 are the ones who really are in charge of the robotic program. They actually run a nodule clinic. So what that means is, if you're a primary care doctor, you might do any test, but if you've done a chest X-ray or a CT scan, and you are someone who found a spot or a nodule, then obviously that nodule is followed over time. So we've actually created a separate nodule clinic because we've realized in our population we actually see a lot of nodules. So it makes sense to have a clinic that is very specifically directed at only seeing patients who come in with these nodules. So that's a new development. Our primary care physicians know about this, and they do their due diligence in directing them to the pulmonologist. It would either be Dr. Oak or Dr. Datar, and then they do the needful. Just because you have a nodule doesn't mean you immediately go under with a robot and get this procedure done, because they will be the ones to decide, because sometimes it may just be benign, and they know it. But if it's something growing, you obviously want to jump on it and get the decision sooner than later. Then cardiac cath lab, as you may all be familiar. if you have a cardiac issue, I mean, you have blockages in your coronary vessels or the vessels of your heart, you are going to be needed to be intervened on by a cardiologist, an interventional cardiologist, who basically can do an angiography, and if they find blockages, they are obviously going to address that. They're going to put in stents. I mean, cardiac disease is one of the number one killers in this country. So, we are actually blessed to have a great team headed by Dr. Mikhail. Others include Dr. Rukos, Dr. Kukas, and we have some newer providers too. But the amount of cardiac volume that we see is actually much higher compared to what we would have seen 20 years ago. So clearly, to support all that, our equipment also was getting pretty outdated. So we made a huge investment in building a state-of-the-art cardiac cath lab. So we kind of completely revamped the whole cardiac area. If anyone has been there, you probably would know. So we tried to put all the cardiology services just in one area. So you have your echocardiogram, your cardiac imaging, everything else that you would need to do, and pretty fancy state-of-the-art stuff. Our cardiologists just love it. I mean, so it's not like they had to learn a new skill set. It is just that the clarity, you know, it's like just having some of our old tube TVs versus the 4K TVs that we have. I mean, we appreciate the improvement in quality. So, similar analogy. I think they really love the new stuff that they have. And I feel these machines have a much longer shelf life than some of the ones we've had before. So really looking forward to help the community with a lot of our cardiac issues. So next I wanted to focus on our recruitment success. And I'll just take a few minutes here. I mean, I've been working in this county for 12 years, and even the first time when I interviewed here, Dan Eckenfels, our president, he was part of the interview committee, and then there was Eric Amons, who was our former president, and really a great guy. And I realized that when I had to actually find the address of the hospital, it wasn't much of a struggle, but I did realize it was a drive because I live in West County. So, and then I realized very quickly when I met this team and I toured the hospital, it was just a very different vibe. I worked in St. Louis University Hospital. I worked in Mercy at Ballas. I've been to Mercy South. But just the culture in this hospital just blew me away. And I wanted to give it a shot for a year or two and then decide if this is what I wanted to do, because teaching is something I was very passionate about. But guess what? I realized it's the people who actually matter more. And I decided to stay, and I was entrusted with the task of recruiting more physicians to the area. And it's always kind of been a challenge, and I don't say that in a negative way. It is just that when I'm speaking to physicians and trying to convince them, they're like, hey, wait a second, let me find this on Google Maps. Where did you say this is? And they look at her, it's like an hour from the airport. I'm like, no, it's not. And then, so there are a lot of factors that go in trying to recruit physicians to the area. So we do our best in trying to sell them the culture, the community, as opposed to just all the fancy toys. I mean, there are several people out there who just want to serve in a community-based practice. It doesn't have to always be about the university, the academia. I mean, some may have the thrill to just do that, which is fine. But I think we've been blessed over the years to bring in a group of individuals who actually would cross 3 or 4 different hospitals to come work here. And that has always been a little challenging, because if you want to really grow services, you want to grow the team. I mean, you want to have services all year long, and not like we'll have urology for 15 days in a month. The other 15 days we won't have it. That becomes a problem. So, that's when we face the challenges of trying to transfer patients out. And I mean, For the longest, I worked in critical care, and I do my best to keep our patients in the community. But there are times where I know if I put my family member in that position, they probably should be in a different hospital. And at that point, I'll be the first to tell them that, hey, I think it's time for you to be transferred to a different facility. And it just amazes me that how much the residents in the community appreciate just being in their own hospital. And we do our best there, but at times we just have to tell them, hey, we have to move you out. But so many people want to be in a hospital where they have every possible service and they don't have to transfer anyone. But that's an ideal state, all right? And it doesn't really happen everywhere. So we've just been blessed that over the years, over the past 3 years, we've actually hired close to 30 physicians. I mean, it's a record. I mean, for the first 8 years that I was here, I think we probably wouldn't have reached 30 over 8 years. And in the last 3 years, I think there has been a lot of recruitment, especially in the last year and a half. And it kind of ties to all the things we are doing with LECOM, Jefferson College. I mean, I'll spend some time on that slide. But what we are trying to do here is address the community health gaps. And we are trying to build a sustainable workforce. So as you will see in my later part of my presentation, we want to build the workforce of tomorrow, all right? So that is going to take a lot of individuals who are committed to not only serving the community, but also committed to teaching. So I think we are blessed there with the kind of cohort that we have built. We have physicians hired in the last several months in cardiology, in pulmonology, endocrine, hematology, oncology, gastroenterology, and general surgery, and we've hired multiple hospitalists, intensivists, ER physicians. So there's been growth all around. And from my day one in the hospital, we've been trying to recruit a neurologist, N-E-U-R-O, neuro. And Dr. Alam is our only neurologist. And I mean, if you want to see a neurologist, not just in Jefferson County, anywhere, it's a 5 to 6 month wait. I mean, I can see the gasps in the crowd, but I mean, it's true, and you know it. I mean, it shouldn't be that way. So our struggles have been no different, and we were blessed. We actually finally, after all these years, have another neurologist. His name is Dr. Kirsch, and he just joined our faculty in July. He actually was in a big town. He was in Cleveland, has family there, has absolutely no reason to move. But as part of the effort, oh, by the way, it took just 14 months to recruit him. I was pretty much chatting with him every week, and over these months, years, we've actually become very close friends. But I mean, what he said resonated with me. He wanted to work in a community-based practice, all right? And he also wanted to be in a setting where he can have students, he wanted to teach, and he did not want to be in a big city. And he's like, this is what I would love to do. And I'm like, perfect. This is exactly the setting you need. So even though he interviewed in some of the other places in the St. Louis area, I mean, we were just fortunate that he chose us. So really pleased to have him. And the day he joined us, and obviously as every morning in administrative huddle, we go over what are the wait times for each specialty. Neurology on one day showed up as 0, like a few days ago. And everyone in the admin huddle area goes like, how did neurology become 0? And then everybody realizes that we now have another physician. So obviously we've closed that gap. So no more 5 months to get in to see a neurologist. We have a new neurologist. He's actually an epileptologist. His specialty is seizures. So there are very few people who are fellowship trained in epileptology. So to actually aid him in doing what he does and could do better, because he's making a huge sacrifice in not being in a university setting and being with us. So if we gave him a unit, there are not many epilepsy monitoring units in the state. And there are 2 in the St. Louis area. And I have a special needs child who actually suffers from epilepsy. It took me a year to get him in, right? It took me a year. And so it's a long wait. So even for adults who need to go through an epilepsy monitoring unit, it can take a while. So he has this skill set, which can, so all he needs is the tools. So I'm already working with our leadership, with our foundation, to see if we can build an epilepsy monitoring unit. And not only, and you will be amazed, we are not only going to serve the community, there is such a big line to actually be in an epilepsy monitoring unit. We are probably going to get half of St. Louis come here if we were to ever do that. So that's how much the need is there. So just wanted to highlight our recruiting success. And I mean, obviously, that has encouraged us to reach out more and try to bring individuals in who kind of share the same passion. We want to create a cohort where everyone has the same wavelength. You know, that is actually the recipe for success. Then among some of the new services, among some of the new services I wanted to highlight, one is pain and spine. So one of the constant challenges in our community that I've heard from almost all the physicians have been our opioid medications. I mean, unfortunately, we've lived through an era where we used a lot of pain medications, and these pain medications obviously have some addiction potential, and it's very hard to take someone off of it. There can be withdrawals, has to be done under supervision, and historically, if someone has pain, you add one pain medicine, pain's not any better, you add two, sometimes three. So I mean, there is a specialty called pain medicine, which only focuses on addressing pain, and that is not by adding more and more pain medications. It's by actually doing certain interventions, actually doing some drug infusions, which can actually help individuals get off of, you might not get off of pain medications completely, but it might help to actually reduce the number of pain medications you are on. So, and in some instances, you could actually come off of pain medications completely. So we launched our pain and spine service because we found Dr. Thang. Spelling is Thang, but pronounced Dr. Thang. And he actually worked in WashU medicine for several years. And we were blessed to have him come here because all he does is interventions. His goal is to get patients off of pain medications. It's never to put them on. And he has a skill set where he can do several interventions, and it may involve pain injections, it may involve doing some procedures that may actually help the individual. And some of these services are also related to helping individuals with back pain. It's kind of a chronic problem that you can find across all the communities. And sometimes he may have to partner with a neurosurgeon. And so the neurosurgeon may only intervene if there is a need to do some spine-related procedures. So I think together they have partnered to actually help us initiate a pain and spine center. We are actually investing more in the pain and spine center. We probably, you'll probably in my next update, hopefully I'll be able to tell you more. But we have some very definitive plans to expand the interventional therapies, and it is part of our commitment to very comprehensive care that we wish to do. Oh, I think it was this next slide. My bad. So I'll move on to the next one. You probably heard about the Farmington practice, and this is a group that is headed by Dr. Moniz in Farmington area, and he, along with his group of other physicians, practitioners, they actually cover about 28,000 lives in the Farmington and the nearby areas. And we have been asked for a while now to have a presence there, and it's been extremely hard with the focus that Mercy has had in some of the other communities. Because, I mean, if you're invested in a community, you need to be 100% invested. It can't be or 50% or anything less than 100%. So, our leader Eric Amons over the last decade has been forging these relationships with these physician leaders in those communities. And just a few days ago, we had a ribbon cutting ceremony there, and we welcomed that whole group, which actually brings in a lot of services, including primary care mainly. Then they also have orthopedics, they also have pain, they also have wound care. And now that we have a pretty significant presence in that area, Mercy now, at least the Jefferson community, Mercy physicians, now plan to have a much more presence in that area as opposed to what we had before. So we may establish more satellite clinics and continue to have a presence in that area. And obviously, once we have more in Farmington, then it probably would include some of the other surrounding areas as well. So it is part of the Mercy's commitment to strengthening the regional network and its continuity of Mercy care across the Southeast region. We actually refer to it as all the progress along the Southeast corridor. So it's the I-55 corridor. So, we have Mercy South, then we have Jefferson, then we have Mercy Perry, and now we have Mercy Cape. So, it's supposed to be that way. It's by design, and they've obviously vetted out all these communities, and Mercy truly believes if it's the calling, you have to be there and serve those communities, just like the sisters did. Then next, I would like to spend a little time on the LECOM partnership. So it's a collaboration with Lake Erie College of Osteopathic Medicine, all right? And it so happened that one of the leaders from LECOM reached out to Eric Amons, one of our leaders, and talked about how would you like to have medical students come to your hospital. So he was like, that would be amazing. And Eric asked me, like, what do you think? Do you think we can actually be a teaching facility? Because teaching facility comes a lot of prestige, and there's a lot of commitment to teaching. Then people go out of their way to attend conferences, come back with more knowledge, and that's the knowledge they want to impart to students. So what we did is we took a team to Erie, Pennsylvania, just to see what they've done. So we were impressed with what we saw. And so Lake Erie College of Osteopathic Medicine, even I didn't know this, is actually the largest medical school in the whole country, all right? And they are an osteopathic school, but they actually have regional campuses across the country. And they have a bigger campus in rural New York, rural Florida, rural Pennsylvania, and their model is very different from some of the other institutions. They actually go to these rural areas where they feel there's an opportunity to grow, and then they start off with medical students, and then they start establishing residency programs. Because as you would know the path, you first have to go through high school, then you go to undergrad in a pre-med track, and then you get into medicine. You do another 4 years, and then you have to do a residency, all right? A residency can be 3 years if you're doing internal medicine. If you're doing surgery or something else, it could be 5 years, 6 years, it depends. So what they were trying to do is, if you have someone in rural America, they probably feel their chances of getting into medicine is not as good as someone who's in the urban area. But what Lake Erie College of Osteopathic Medicine does is, it actually prioritizes first-generation physicians. So you have no one in your family who's ever been in healthcare, you go to the top of the list. And then what they do is, you get recruited out of high school. Typically, to get into any MD program, some of the other DO programs, you have to have MCAT scores. Those are tests that are highly competitive. People try to give it 2 or 3 times to get the right score. Very stressful for these young kids to actually take that and eventually get into medicine. So what they do is, they have a very different formula. They obviously go with getting students right out of high school. And they partner with, like Jefferson College, Maryville University. Now they are partnered with SLU. So they partner with all these colleges in the area that can actually have a pre-med track, or they help them set up a pre-med track, and they give them the coaching that is needed to maintain a certain GPA, and I mean that assures them of a spot in LECOM's medicine program. So I actually have the distinction of working with students who actually come out of some very rural communities, and they are first generation physicians, and they are here only because they were able to get into the early acceptance program of LECOM. They are also on US News and World Report for being one of the institutions with the lowest tuition. So that definitely helps students make that decision as well. And I mean, when you train in a rural environment, a semi-rural environment, if you've been there for 5 years, over 5 years, the data shows you're more likely to practice in that area. And that is exactly what we are trying to do here. So what we do right now is the students of LECOM, let's say, I'm just giving you a future state, what's going to happen is we are going to have students from our community sign up for the early acceptance program. I mean, they may get picked for the early acceptance program, which means they have a spot reserved in 4 years. Then they have to go through our colleges, make sure they maintain that GPA, get into medicine. Right now, in current state, they will be in Erie, Pennsylvania for 2 years, which is their classroom medicine. Then they come to Jefferson Hospital in our community for 2 years of clinical exposure that they need. And then, in the next slide, I have the plans to actually establish residency programs here. So if we had residency programs here, mainly primary care based, then they will do 3 years or 4 years of residency here. So as you can tell, they've already spent more than 5 years. There is every likelihood you work this long in a certain area, you're bound to stay back. So that's kind of our master plan that Dan and I have been scheming. So hopefully it works, but it is the recruit, train, retain model that has worked in other rural communities, and that is exactly what we are trying to capitalize on. All right. So moving on, would like to focus on residency planning. As I said, we don't want to have cardiothoracic surgery residency or fellowship here. That's not what we are aiming to do. Our needs are primarily internal medicine, all right, family medicine. Our needs are psychiatry. Talk about all the mental health issues you hear everywhere. So that is what we need. And transitional year is just a 1-year program before students can do certain specialties. So, but we are basically investing in internal medicine, family medicine, and psychiatry residencies. I mean, psychiatry, we are blessed. We have a adult unit. We have a gero psych unit because in individuals above 65, you have more mental health related issues as well. So we have a separate unit for them. And with the establishment of the intensive outpatient program, it has worked great. I mean, there are so many things we can do with the IOP that we don't have to have all individuals with mental health problems admitted to the hospital. So the key is to retain physicians in Jefferson County and build a strong academic pipeline with LECOM. It kind of ties to the previous thing that I was trying to explain. Then, excuse me, research. So research has historically been associated only with university programs. I mean, when you talk of WashU, when you talk of SLU, I mean, you talk of all the research programs they have, yes, I mean, you wouldn't normally expect a place like Mercy Jefferson to be involved in research. But now we are, and that's some of the work that I wanted to share with you guys. So as I told you, I have a background in infectious disease, critical care, and so when it comes to sepsis, sepsis is again a killer disease, all right? Most of our patients admitted to the hospitals, I mean, they are admitted with sepsis. Once you are very sick with sepsis, I mean, the mortality rate can be 50% and above. So what is very important with sepsis is early diagnosis, all right? I mean, and right now we don't have any tools. We are still using some outdated algorithms, and it comes down to the clinician to kind of really facilitate the management, diagnosis. While there are some novel diagnostic tools out there, I mean, we've actually partnered with one of the pioneers, and that's the company called Prognosis. So just to give you an example, you may actually have someone come in with what may appear not a very bad infection. And you might think this is someone you could treat. And sometimes the infection may not even manifest itself. They may just not feel good. They are in the ER. They may actually be completely sound mind. They're having a conversation with you. But in today's state, you couldn't tell if this sepsis is brewing in there. 6 to 8 hours later, this individual could be in the ICU, on a ventilator, on multiple medications. But we can't predict that today. But with the tools, or in the future state that we imagine, we will be. Because based on some blood tests that you would get done at the onset itself, this company, Prognosis, this is, oh, I'm so sorry. I think I'm a little slow with my thing here. Yeah. So, so this is a paper that was published in the New England Journal of Medicine. For anyone in the field of medicine, any JM is kind of our Bible, all right? So anything published in there, it goes through a lot of intense scrutiny and gets published, and a lot of the guidelines that healthcare follows, it would actually come from some papers published in the New England Journal of Medicine. So, surprisingly, you will find there are 4 doctors, including myself, from Mercy Jefferson in this paper. So this is an FDA authorized. It's the only FDA authorized AI is artificial intelligence, ML is machine learning tool for sepsis prediction. So this is actually a paper we've been working on since COVID. There was I put together a team who still wanted to work despite everything that was going on around them. While we had to work overtime with the situation we were dealing with, we still wanted to play our part in contributing to the field of medicine and research. So we actually analyzed a lot of charts. We worked with all these researchers, and they've actually put together this algorithm, which, this is step 1, phase 1 of the research. Phase 2 will happen in the next few months, and hopefully that will also get published. Then we will actually come to a state where hopefully the guidelines will change, and what we are trying to show through this is if we are able to detect sepsis way early, you might be in a state where, yes, you are able to talk, you look fine, but through that blood test, it's going to give me a probability score that you are very likely to get sepsis, which means we start the antibiotics early, we start you on some heavy dosages, we would give you fluids, a lot of things which otherwise would follow several hours later. Because in today's date, until we really know, we can't begin to treat, because that's kind of how the sepsis treatment is done today. But in the future state, we will be doing things different. So I think this is one of the things I'm really proud of, that we actually have our names with some of the other physician scientists. This is all they do. But they were so impressed with what physicians and the team at Mercy Jefferson did. They actually decided to extend this partnership, and they're coming back to do the phase 2 with us as well. So I think it's really a matter of big honor to actually have such big teams come to us. They are currently working with places like Harvard, Emory, and now Mercy Jefferson is part of the team. So really excited about that. Then, I mentioned WashU research there, only because teams from WashU are now reaching out to us that, hey, we hear you have a knack for research. We got some projects you could help us with, and can we partner with you? So we are actually in talks with them. I'm not at the liberty to discuss more, but I think it's pretty exciting. It's all research related to stuff that is going to benefit the community in the future. Then I think I just have a couple more slides, Dina. Then just wanted to briefly mention some partnerships we have, Mayo Clinic, very famous name. I think Microsoft is a household name. And, and Alice Walton Foundation. I mean, these are three of the, I mean, Mercy has several partners, but these are three partners I wanted to highlight, only because these three partnerships, they position Mercy as a national leader in healthcare transformation. Mayo Clinic brings world-class clinical expertise. Microsoft delivers cutting-edge digital capabilities. And Alice Walton Foundation, it ensures equity and community-centered impact. They're actually doing a lot of work with the Alice Walton Foundation in Arkansas. So you'll hear more about that with time. But together, they enable Mercy to provide smarter, more accessible, and more compassionate care for the community it serves. So I think in the years to come, I think the partnership that we have with these individuals, or sorry, with these companies are going to be big, because just as I said, the world is evolving. I mean, we talked about AI. I mean, information is so vital in healthcare. And when I say information, I'm talking about information related to diseases. I mean, in Mercy Jefferson, if I were to pick a disease, I may probably have a small cohort. I can't predict the disease patterns just based on a small subset of patients from Mercy. But when some of these leading organizations get together, they don't share patient-related data. They share how the disease behaves. So if you were to know how the disease behaves, what genes it affects, and what can be targeted, the future state of medicine could actually identify high-risk individuals and actually develop some novel treatments to treat them even before the disease happens. So I mean, we are actually in that state right now where there is a lot of considerable work going on it. So the next few years, especially the next decade, will actually be full of surprises, I would think. Then lastly, I love this slide. So this could be your future physician. It could be your future speaker here in a few years. So the AI integration in care and operations is just going at a pace that really no one imagined. I mean, every conference I attend, I mean, 90% of it is centered around AI and how it's going to be integrated. I mean, I personally have a cautious approach towards it. Why I welcome technology and AI, I still feel the compassion, the empathy that we humans have. I mean, I doubt AI will ever possess that. So, and in terms of a future state, I'm sorry, I think I'm a little over, but I do want to talk about, I did say that working with Dr. Kirsch, our neurologist, to kind of work on an EMU unit, then bringing in more students, working on the residency program. The more learners we have in the area, the more people we can draw in, because there are many physicians out there who not only want to work in a community-based practice, but they are on a hospital, but they also want students around them. They want to learn, because when you have people around you and you have to teach, you have to be well learned to teach them. So I think it keeps them up to date with all the knowledge they should possess. So I think it's good to have that. And what we need is more students, more physicians, more nurses, and eventually that is going to make a very strong impact. And together, we will shape the future of healthcare in Jefferson County. So thank you.
Okay, we have time for questions if anyone would like to ask some questions. Laura, I don't think you were in there when I said I have a 1 o'clock meeting that I have to join virtually, so I'm going to hand you the microphone. Do you mind? And I just want to thank you really quick. He is leading great work at Mercy Jefferson, and I can say that we get to partner here at Jefferson College with them all the time, and I just want to give one example. We have about 500 high school students on our campus every day through our area technical school for learning a trade, and we have a health services program in there. So the first year, a student can become a CNA, sit for that certification. Second year, students may choose the pre-nursing program where they can become a patient care tech. And we've worked with some of Dr. Iyer's colleagues, and they get hired by Mercy as a PCT. They have to meet the standards to get into our nursing program, but after they become an LPN in our nursing program, that's after the first year, they will then promote them to an LPN. Then they will hire them as an RN once they pass their boards, and then they'll pay for their BSN. So students have a great opportunity here to get all that training and be working full-time at Mercy. So we have worked really hard on those technicals. Thanks again. I'm going to turn it to Laura. Here's the question right there. And I'll see you guys next month.
Okay.
You talked about recruiting
careful.
physicians, but what about nurse practitioners and nurses? We have a lot of friends that are retired nurses, and they talked about the stress and the overload of patients. And so how is that changing for the upcoming students that want to get into that part of healthcare?
Sure. Very good question, and we've been constantly working on also increasing the number of APPs. So we call them advanced practice providers. So that includes nurse practitioners. It also includes physician assistants. So we have a pretty decent cohort in our hospital, but we would like to have more. And in fact, we struggle with APP hiring also, only because when we talk about any advanced practitioners, we try to bring them in, we try to train them, because they can basically go to any field they want. So as in, some may choose to go into primary care, some may want to be with orthopedics, some may want to be in pediatrics. So there is a ramp-up time before we can get them to a position where they feel comfortable. I mean, they will always, I mean, as it stands currently, they need to have physician supervision. In a future state, maybe it may not be necessary, because in some states it's not, but in our state it is. So, so basically, in fact, even the Farmington practice that we acquired, I mean, they have a lot of APPs. So I think what works best is when you have APPs from the community. I mean, we were lucky, we hired a couple of them who are actually from our area. So, so you're able to hold on to them. Because with APPs, what we see is there is a lot of movement. Like as in, I mean, it's hard to keep them in the community. We tried our best to kind of create. So we are actually working on that situation right now. And we see that wherever Mercy has a presence in different states, they are also seeing that we have to work on not only the, when we talk of recruitment, not only help with recruiting more physicians, because a lot of our physicians, for instance, if we talk about people who do procedures, so we've gone to a state where our physicians are spending more time with procedures, and our advanced practitioners are the ones seeing patients in clinic. Because that's the only way you can actually get, you don't have a backlog of all these cases. Because the way we historically did things, if someone needs a colonoscopy and has to wait 6 months, and I mean, you may have an opportunity to detect a tumor much earlier than what you would eventually have. So if you kind of have a model where you were seen by someone on the team, all right, with all the tools they need to have, if they saw you early, you could have your procedure done sooner. Because if the proceduralist is spending too much time in the clinics, so kind of we are ourselves seeing a lot of change in how healthcare is being done. I mean, we would all love to see the physician, but we also now have a team full of APPs. So the more APPs we have, I think that's actually the way to move forward. And I think all health systems are seeing value in that. But we need more APPs. That's all I would say. I don't think we have as much as we can support today, but we would need more. And the health systems have to actually open their mind to having more APPs. I can speak for Mercy. I know Mercy likes to have more APPs, and their plans for 2030 actually have inclusion of more APPs, not only in the outpatient setting, but also in the inpatient setting. So we will see more APPs. So, if you have friends, please refer them to us.
Oh, they're retired.
Oh, okay. Yes.
I want to thank you, doctor, for coming and enlightening us. I had no idea what all was going on at Jefferson Mercy Hospital, so thank you. And are you considering maybe doing an open house program with the hospital to where we could learn more about what's going on?
Oh, yeah. So, great thought. I can definitely discuss it with my leadership team as well. And obviously, we'll continue to communicate with Dina. And yeah, I think I like that suggestion. Yeah, we'll incorporate that. Yeah, thank you.
Any other questions?
I'll make a comment. We moved out here 45 plus years ago, and it was said, oh, don't go there. So we would go into St. Anthony's all the time. But now this is so encouraging to think, no, I'm going to come this way for a change and go to Jefferson more. What's your name? I don't
Mercy Jefferson Hospital.
All these new names. It's still St. Anthony's, guys. But yeah, it had a very bad reputation back then, but not any longer.
Okay. No, and I really appreciate that comment because I joined Mercy Jefferson at a very transformational time where they went from being Jefferson Memorial to Mercy. And I cannot tell you the number of patients I have met who have actually shared the same things with me. Like they would actually avoid the hospital just because of it not having a great reputation. But and I can just tell you, even the staff, like the culture, like when I was working my first week, I asked them to do something, and they looked at me like, "You're not from here." I'm like, "Yes, that's pretty obvious." But they're like, "You didn't work here." I'm like, "No, I didn't. This is my first week." Where were you before? I said I was at Mercy St. Louis. St. Louis, that makes sense. They're like, "Doc, we do things differently here." And I had to tell them that when we say something is standard of care, it means it doesn't change. You could be in the most rural place you can think of, but the care doesn't change. And that's what we've tried to inculcate over the years. And now, if you speak to anyone in Mercy Jefferson, because we get compared to all other hospitals. So none of my team members want to rest with some accolades that tells them you're good, we want to be best. So we are currently a 3-star CMS hospital. We actually conduct a program that is the road to 5 stars. So, and those are all very stringent quality guidelines that we have to meet. And so we strive every day to make sure we can get there. So I appreciate the comment. Thank you. Oh, I think some.
When are you gonna plan on doing more for the heart surgeons? I mean, like they sent me to St. Anthony's for heart surgery for TAVR, but you could have done it right here, McKell said.
Yeah. Great question, and I'm glad none of our cardiologists are in this room because it was something we were very passionate about. Because even when I joined Mercy Jefferson Hospital, we had a cardiothoracic program. We had Dr. Suin, we did all kinds of surgeries, we had great outcomes, but when we kind of brought in St. Anthony's, now Mercy South, then you have to look at some of the bigger logistics. And I can just share a couple of minutes on that. So when we talk about having, now Mercy has 4 different hospitals in a 100-mile radius, all right? So we have Mercy St. Louis, Dallas, we have Mercy South, we have Mercy Jefferson, and we have Mercy Washington, all right? So, that's 4 hospitals. So if each hospital decided to have their own heart program, you would need to have multiple, I mean, we are first talking about equipment, all right? You have to build space for that, you need to have the equipment. Then you need to have several teams on call. I mean, when you have to hire a team, you have to have someone, like especially for heart surgeries, 24/7 available. So it's very hard to find, to put one team together is hard, who are always available. So to have 4 of them in 4 locations is very hard. And I mean, as much as it was a great service to the community, it was something we struggled. We didn't want that. But the Mercy leadership made us see some value in it, because if you look at I mean, if you were to just take a peek at any health system, I mean, take a look at SLU, take a look at St. Luke's. I mean, the program from Dipper went to St. Luke's. The programs from all their peripheral hospitals, including St. Clair, their heart program has now gone to St. Louis University Hospital. So what they are trying to do is they are trying to concentrate some of the bigger surgeries, like heart surgeries, brain surgeries, in a much bigger setting. In a bigger setting, and what that enables them to do is have that continuous 24/7 coverage that you need. Because if we had a program, and if for, let's say, because then we are competing for the personnel who are part of that team. So which is why Mercy made a decision just to have 2 programs, and the other 2 programs, Washington and us, we would feed into them. So if we have a patient who our cardiologist intervened on, and they feel this patient needs surgery, we have a direct line with Mercy South, and where the surgeon would pick up the phone, and we do our best within the next hour that patient would be in their hospital. I mean, they would get there in 30 minutes, but that whole process of getting the rig, transferring them, it would probably take some time. But that's what we would do. So as much as it is a pain point for all of us, and like I said, we would like to have all the services in the community that the community would need. Some specialized services, it is probably best to be in a much bigger location, because you need more physicians, you need more OR staff, you need people who would specifically work on some of those instruments which no one else would. So the more specialized the skill set, the fewer people you can find with that skill set. So it's best to have it concentrated in the way we do it. Okay.
Okay. Any other questions? All right. Thank you again, Dr. Iyer.
Sure. I just wanted to thank you all for being with us.